Good afternoon, everybody. Thank you very much, current president and past president of Vietnamese Neurological Society of Vietnam, for this kind invitation to beautiful city of Phuong Dao, Vietnam. I've been here supporting neurovascular intervention for 21 years, and we should celebrate these 21 years of collaboration. And it's impossible to make the strength of the Vietnamese neurovascular intervention without supporting from neurologists team and neurosurgical team and neuroradiologists. So this talk is going to be for the very rare disease called spinal arteriovenous shunt that I would markedly into the name and the clinical presentation of each group. By simple classification, I would like to introduce the anatomical space from paraspinal, epidural to dural and intradural location of arteriovenous shunt. And if you have the metameric lesion involving all the space, you call metameric. Some of the arteriovenous shunt are related to genetic and hereditary. We can name following the size and flow of the shunt, for example, micro or macro shunt, single or multiple. To our knowledge, we know that each group are supplied by each type of artery. So spinal vascular anatomy is mandatory to know that, for example, dural arteriovenous shunt are fed by radiculomeningeal artery, while the pyochord arteriovenous shunt are supplied by either radiculomedullary or radiculopyo artery. And it can divide into the glomerular or plexiform nidus type or fistulous type. We start with something outside the dura called extradural arteriovenous shunt. You can notify that the shunt is fed by the artery outside the dura. So when the shunt opens into the outside dura, there could be two spaces, the paraspinal and epidural site, usually diagnosed in childhood and young adult. So the symptoms are usually just bruit, hurt along the cervical or the back of the patient. Some of them may have the congestive cardiac failure in the young age group because of the high flow shunt. But mostly the clinical presentation are related to the venous drainage. For example, stealing, compression, or systemic. This is example of the three cases, different cases. The first one is one with the venous pouch compressing. You see that the flow void, the big flow void structure is the venous pouch compressing the cord and the nerve root. The second one, you see the edematous myelopathy or edematous cord related to the shunt. And the third one, you have mixed between the mass effect of the venous shunt and the edematous cord. And this is the angiographic pattern of each of the group. This first, you see that the shunt actually located here, which is epidural shunt. And this one is also same location of the shunt, but the venous drainage pierced into the dura that make the congestion of the spinal cord. And the last one, you can see multiple feeders came to the dilated venous pouch and compressed the cord. In the recurrent epidural hemorrhage, you may have seen the recurrent epidural hemorrhage. Check whether you are facing with this dorsal epidural shunt, that if you have a chance to embolize or stop the shunt, you can stop the recurrent hemorrhage for the patient. And this group can present it with subarachnoid hemorrhage when you have the shunt and drain directly intradural veins. So if you have this subarachnoid hemorrhage and you cannot find the cause in the brain, think about it. So this is example of the venous pouch compressing the cord. You can see the big venous pouch and myelopathy was seen there. And if you do angiogram, this is the lesion that called vertebral arteriovenous fistula. It's in the group of paraspinal epidural shunt. And if you know exactly where is the shunt, you just put the balloons or embolic material that you can stop the shunt and the patient can regain normal neurological symptoms later on. For example, this is a follow-up before and after. The pouch collapsed into the scar and never come back again. Now the epidural shunt can be a small one like this. You see that in angiogram, you see the shunt is a strange-shaped veins. And this veins is actually part of the epidural venous plexus that is isolated or thrombosed proximal and distal part. So all the shunt drain back into dura here. So this is the drainage going back. So you can have this kind of very, very congestive along the thoracic spine with this drainage. And the shunt was just outside the dura. This is example you may face with a patient in the age of 50, 60 with the classic myelopathy. And you fix the level of sensation. For example, this guy is having the thoracic 8 level paresthesia and progressive paraplegia for 2 weeks. You look carefully, you see the white signal or hyper T2 signal along the cord. And you see these tiny, tiny little vessels, which you should not see in normal patient. This was misdiagnosed as a transverse myelitis or ascending myelitis for some days. Before reaching us and you put the gadolinium, you now see that all the vessels enhance in either ventral or dorsal to the cord. Immediately, I recommend you to go to the MRA of the spine. This is now becoming the very mandatory investigation for any suspected spinal arteriovenous shunt. Instead of putting the catheter right away into all the segmental artery, you use this MRA of the spine. And now you see that there is early veins, early arterialized veins. That means the direction go from down to up. That means the shunt must be located downstream there. So this is 3 phases. You can make it 2 or 4 or 5 phases, depending on your MRI machine. And this is the same patient. When you see that exactly at right L3 level, you hook into this and you found the shunt located there. For sure, you need to do the normal spinal cord feeders. And now you save a lot of time by putting the embolic material, and this is before and after treatment. You can cure all the disease and the myelopathy regain back to normal. Now we come back to the second disease, which is the most common spinal arteriovenous shunt. It is the dural arteriovenous shunt. We believe that the shunt is either located at the dura around the nerve root or immediately inside the dura at the junction of artery to the radicular veins, which finally drain into the perimedullary veins and make the symptoms of the patient. We published this classification of the dural arteriovenous shunt between the brain and the spine. It was done many years ago. And we found that most of the dural arteriovenous shunts are in the group of lateral epidural space related. So for sure, the myelopathy can be coming seen from all of these dural arteriovenous shunt. Classic imaging finding, it's not just the hyper T2 weighted, but you can see all of these enhancement. And it's not a good prognosis. If you see this hyper T2 cord with a lot of vessels around, and you see pattern of enhancement, either ring enhancement like this is ring enhancement, you see, or patchy. This is Salchow enhancement, this is patchy enhancement. These 3 types of enhancement, you can talk to the patient that This is not a good prognosis. There are good correlation between enhancement and poor prognosis, because the length of the symptoms are related to this enhancement. So that means even you can finally treat the patient to the curative stage, the sign and symptoms may not come back to normal. It's a bad sign that you can have the focal myolytic change of the spinal cord. Bleeding can occur. We used to believe that there is no hemorrhage in the dural arteriovenous shunt, but it happens in the high cervical or foramen magnum level shunt, that you can have this kind of hemorrhage. And check whether it's out of the textbook now that dural arteriovenous shunt can present it with hemorrhage. Let me talk a little bit about MRA of the spine. I mean, this is example of if the good quality MRA, for example, this one, you can check that the actual feeder are located there. Look how the correlation between spinal angiogram and good quality MRA will bring you exactly that the dural shunt is located at this level. And you know that by your knowledge, you need to occlude both the shunt and the proximal veins and not spreading all the contrast into the more distal veins. We were publishing the lower down articles that belongs to our own Thai way of injecting contrast in MRA compared to the original one above that Richard Farb and the Toronto team published years ago. You may adjust the technique by your machine, either 1.5 or 3 Tesla, and the time of catching the contrast that you inject. For example, this one, you see that there is arterialized veins at that level, and you immediately correlate it with your spinal angiogram with exactly same shape, same location. Now you know that for all these, tortuous of the vessels, you zoom. And when you zoom, this is the way that you go with your micro catheter 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. When you get there, you know that your embolic material should include distal veins and proximal artery a little bit, so that you can have the good result. And this is what we published, that the accuracy and the sensitivity and the specificity are not bad compared to the original one from Toronto team. Again, look at the shape of this dural shunt. This is 3 phases, and you know that the shunt should be there, and this is radicular veins that drain all the shunt. And this is, again, the example of this lady with this myelopathy ascending from the conus medullaris up, enhanced blood vessels. And now you know that by doing that, you may have hard time to see. In some case, you have hard time to see. You know that there is some abnormal veins located there. But what about the shunt? So if you look carefully and you do this, finally you know that you detect at this level, at least at this level. So your catheter will be hooked into that level. And try to see down from that whether you can find this example of the shunt lower down. There are misdiagnoses in MRA. For example, radicular AVMs, epidural AV shunt, or the draining veins slow in the perimetrally arteriovenous fistula. This is location of the shunt at the foramen magnum. So it's not easy that you put your MRA at the thoracic, and then you need to put a little bit more contrast to extend up or extend down. So there are 2 spots that you may miss, is the foramen magnum level and lateral sacral levels. So this is an example. What do you do when you miss this? This is hyper-T2 myelopathy blood vessels around the spinal cord. You see that the first, second, and third phase, you see abnormal arterialized veins, dorsal and ventral to the spinal cord. You know direction So you must find something below. So this is how we find that there is a tiny, tiny little shunt from lateral sacral artery reaching up intradurally and congest entire the spinal cord so that you can have chance to treat. This is again another strange MRA, but you see this arterialized pocket down there. This is example of focal epidural shunt that finally drain intradurally. This is again the foramen magnum level that I show you. By doing the anatomy, you know that at the foramen magnum, you must inject ascending pharyngeal and occipital artery. And now you see that by injection of this ascending pharyngeal artery, you see clearly the shunt located there. By injecting vertebral artery, you may be confused where to occlude this shunt. And this is how we can treat the patient, and the patient becoming normal after the treatment. Don't forget that in this group of misdiagnosis, you see this and confused that this is a radiculomedullary artery or not. Finally, you analyze yourself that this is all the veins, and the shunt is located at the dural level. So be careful to misdiagnose all of this anatomy. The glue must cover the shunt and the proximal veins. We come down to the almost the end, which is called conus medullaris, or in the anatomy we call basket. It's the connection between the ventral and dorsal system. So when you have the shunt located at the filum terminale, which is below L2 in the normal anatomy, you can have these images of the artery becoming down, and becoming bigger vessels, which is the veins. This is the filum terminale arteriovenous shunt, which can be presented with the venous congestion of the entire spinal cord, same as the dural shunt. Don't forget that this is in differential diagnosis of dural arteriovenous shunt, which is called filum terminale AV shunt. This is another example of differential diagnosis. You see this injection of the Adam-Kiewicz, which is the major radiculomedullary artery coming down to the basket, and anastomose with the dorsal system, which is the radiculopyral artery, and becoming the veins there. So you know the shunt is located right side on that level. You are for sure knowing that if you inject the system of the dorsal system, both sides, you fill up the arteriovenous shunt at the same level. So now you know all anatomy and you choose which vessel you are going to go for treatment. And what I said to you that we published these so-called radicular AVMs, which is AVMs just along the nerve root. So the symptoms of this group of patients are a little bit different from the dural, which is more radiculopathy. So if you have more radiculopathy rather than myelopathy, think about this possibility of the radicular AV shunt, that for sure we do the same embolization. You cover the shunt and the proximal veins. And this is, for example, the lesion that can congest the entire cord. It's the radicular AVMs. Now we come to our intradural or spinal cord. You can point to either micro or macro fistula. And this group of fistula, which is, again, it's just the superficial located intradural or spinal cord AV fistula. Usually it happens in younger age group, and you can see this, a lot of other things. You can have hematomyelia, you can have myelopathy, you can have big vessels. And this is the angiogram that shows you probably the shunt located there, and it's at the surface of the cord. And if you have a chance to just put close up the fistula, you can bring this patient into curative treatment. Again, younger age group with this, I was sent to this case to differential infiltrative spinal cord AVM. But actually, it's just a fistula located at the surface of the cord. And the rest are the intrinsic venous cord congestion. It's not the nidus. So this is how we treat this group of patients, that you just put a little drop of glue to close the fistulas at the superficial part of the cord. And the result is superb. You can have this type of follow-up. Macrofistula in children. This is misdiagnosed as the tumor of the spinal cord, but we found that actually it's a macrofistula, and all type of fistula are shown there. You must check the association of these with HHT or rendo-oscular Weber, because this is one of the classic imaging of the single macrofistula that can be seen. We work together with Dr. Kung for this case, and he has a beautiful illustrative that with this macrofistula, we can do nicely, put the catheter through sulcocommissural artery and put a drop of glue, and then later on be able to get the curative result. This is, we worked together many, many years ago. And within this spinal cord malformation, the presentation should be, it's a male disease, and it's younger age group compared to the dural shunt. The spinal cord shunt is younger. And the hematomyelia can be extensive from the located area and extend up or down. It can also be subarachnoid hemorrhage. And when you have the spinal subarachnoid, if you have the subarachnoid hemorrhage in the brain, you cannot find aneurysm in the brain. Please come down and do MRI of the cervical area. And we have the incidence of more in the cervical area of the spinal cord. There are real angioarchitecture that responds for the hemorrhage that we call the flow-related aneurysm, the false aneurysm, the pineal venous congestion. So that we do partial embolization. That means we just hook into the aneurysm that creating the bleeding in the spinal cord. And if we do embolize that very fragile type of angioarchitecture, you can live with a little tiny nidus. You don't need to eradicate all the nidus because you're going to be in trouble and try to do that. And this is how we try to do little by little and make sure that you get better outcome. Not only the hemorrhage in the spinal cord, but you can have the mass effect. Don't forget that you can have syringomyelia related to the spinal cord, AVM, and for sure myelopathy. Multiple AV shunt can be metamelic lesion. What we call metamelic lesion is the same embryologic segmental arrangement of the vascular malformation. And don't forget that, as I told you, this is a case of HHT or rendo-oscular Weber. They have multiple microbrain AVMs, pulmonary fistula, and look what they have in the spinal level. So they don't forget. Another case, pulmonary AV fistula, familial epistaxis. Go to the familial history, and you find in that spinal cord single macrofistula that support your diagnosis of HHT. Metameric lesion is what is shown in this drawing. This is a case here in Vietnam. They have beautiful cases to be shown. And the patient was having this skin subcutaneous muscle, all malformation along, and the spine and spinal cord vascular lesion. For this case, they have high flow paraspinal arteriovenous shunt, and this is the angio that was shown, and you just know this is used to be called COBS syndrome, COBB COBS, and now we try to move it to the spinal arteriovenous metamelic syndrome, or SAMS. So you count the level of SAMS following the metamelic lesion. For example, you can have this level that you count from SAMS 1, 2, 3, 4, 5 down. So you have SAMS 31 level, right and left. Don't forget that even this metamelic, you can include radicular. This is the imaging that shows the radicular AVMs and the spinal cord AVMs of the same level. So that means you are now getting the radiculopathy and probably the spinal cord symptoms of the same patient. So that is the way to put it through. My last slide is that don't forget that the history are the key, because some diseases cannot, for example, spinal duration cannot happen in younger than 25 years old because it's the aging, it's acquired disease. While the paraspinal mostly occur in younger age group, the spinal cord usually in the middle or younger age group. And then the clinical presentation is very important. Imaging, I highly suggest you to go with a spinal MRA. And for sure, at the end, when you want to treat, you go with the very good spinal angiogram, not the one that reflects into the aorta. And then you know the classification that we talked in the first slide. You go to the natural history of each disease, and then you put the therapeutic management. For sure, treatment will be there and follow up. And you know that spinal vasculotomy contribute in every step of your diagnosis and treatment. Thank you.